CICU devices.
Impella RP. Key clinical concepts. For more insights on Impella device, we recommend you to visit our Impella Guide playlist on the CICU Devices channel. The Impella RP represents a significant advancement in percutaneous mechanical circulatory support for right ventricular failure. It is a microaxial flow pump designed to provide temporary hemodynamic support by directly bypassing the failing right ventricle, drawing blood from the inferior vena cava, and delivering it to the pulmonary artery at flows up to 4 liters per minute. Its clinical purpose is to unload the right ventricle, reduce right ventricular work, and maintain pulmonary circulation while the myocardium recovers, or while the patient is bridged to the next therapeutic step. The device consists of a 22 French impeller and cannula mounted on an 11 French catheter shaft. It is inserted via the femoral vein and positioned across the right heart, with the inlet located in the inferior vena cava and the outlet in the pulmonary artery, enabling direct unloading of the right ventricle and restoration of pulmonary circulation. You can learn more about Impella physics and physiology in this video. The link can be found in the description. The device is indicated for temporary right ventricular support for up to 14 days in patients with a body surface area of at least 1.5 square meters who develop acute right heart failure or decompensation within 48 hours after myocardial infarction, after open heart surgery, heart transplantation, or left ventricular assist device implantation, provided that profound shock, end organ failure, and acute neurologic injury are not present. In this context, the device is mainly used as a bridge to recovery or bridge to another advanced therapy. The Impella RP is contraindicated in patients with pulmonary artery wall disorders that prevent correct placement, in patients with tricuspid or pulmonary mechanical valves, in patients with severe stenosis or regurgitation of the tricuspid or pulmonary valve, in presence of mural thrombus in the right ventricle, right atrium, or inferior vena cava, and in the presence of a vena cava filter or anatomical limitations preventing safe catheter insertion. The implantation procedure requires fluoroscopic guidance and is typically performed via the right femoral vein using a large bore introducer. A guide wire is advanced through the right atrium, right ventricle, and into the pulmonary artery, over which the Impella RP catheter is positioned. Implantation is performed percutaneously, preferably via the right femoral vein, under continuous fluoroscopic guidance. After femoral vein puncture, the 23 French peel-away sheath is inserted. Then, a flow-directed, balloon-tipped catheter, like the Bergman catheter, is advanced into the left pulmonary artery. An 027 guide wire is then advanced through the balloon catheter, which is subsequently removed. The Impella RP catheter is then advanced over the guide wire and positioned with its outlet in the pulmonary artery and the pigtail pointing to the left pulmonary artery. Finally, after insertion, the peel-away introducer is removed, leaving the 11 French catheter shaft in place, and the entire system is secured with a mattress suture. Correct placement is essential for effective support and for minimizing complications. When properly positioned, the inlet area of the catheter sits in the inferior vena cava, and the outlet area is located in the main pulmonary artery, allowing blood to be drawn from the venous side and delivered into the pulmonary circulation. Once properly positioned, the system is activated via the automated Impella controller, which regulates pump performance, displays hemodynamic parameters, and provides real-time alarms. Therapy adjustment is managed through the console, which provides the user interface, monitors pump function, and controls performance levels. Support is adjusted using performance levels or P levels, which regulate pump speed and flow. Adjustments are usually guided by clinical response, central venous pressure, pulmonary artery pulsatility index, and end organ perfusion. Systemic anticoagulation is mandatory to prevent thrombosis within the catheter, with alternatives considered in cases of heparin intolerance. The purge system is also essential to therapy because it creates a pressure barrier that prevents blood from entering the motor. Standard purge fluid is dextrose solution with heparin, and if heparin is contraindicated, sodium bicarbonate may be used instead. Saline should never be used in the purge system. During support, continuous monitoring is essential to detect complications, such as suction events, malposition, or purge system abnormalities. Central venous pressure, pulmonary artery pulsatility index, and cardiac index are useful markers of response, and improvements in these parameters are expected when support is effective. Recommended goals include central venous pressure below 12 mm of mercury, mean arterial pressure above 65 mm of mercury, cardiac index above 2.2 liters per minute per square meter, and mixed venous oxygen saturation above 55%. Concomitant medical therapy should be optimized, including pulmonary vasodilators such as inhaled nitric oxide or epoprostenol to reduce right ventricular afterload, and judicious use of inotropes such as milrinone or dobutamine to support native ventricular function. Volume status requires careful management, as excessive preload can worsen right ventricular distension, while inadequate preload may compromise device flow. Serial echocardiography guides assessment of right ventricular recovery, monitoring for improvements in right ventricular ejection fraction, decreased right ventricular dilation, normalization of septal position, and improved tricuspid annular plane systolic excursion. Chest radiography performed daily should confirm the characteristic pigtail configuration in the left pulmonary artery without advancement into branch vessels. Weaning from Impella RP support should be considered once there is evidence of right ventricle recovery, including improved hemodynamics, reduced inotropic requirements, and adequate end organ perfusion. This involves gradual reduction of P levels while closely monitoring for hemodynamic deterioration. Device removal is performed percutaneously, typically after reducing support to minimal levels, ensuring hemodynamic stability, and carefully extracting the catheter to avoid vascular injury. Finally, hemostasis following device removal is achieved with a new mattress suture. Potential adverse events associated with Impella RP include bleeding, hemolysis, arrhythmias, infection, thromboembolism, cardiac, vascular or valvular injuries, and device malfunction. As a final point, a brief comment about the BiPella strategy. The BiPella strategy refers to the simultaneous use of two percutaneous Impella devices to provide combined biventricular mechanical support in patients with profound biventricular failure. In this approach, one device supports the left ventricle, while the second device supports the right ventricle, allowing more complete unloading of the heart and improving systemic and pulmonary circulation. BiPella may be considered as a temporary rescue strategy in highly selected patients when isolated left or right-sided support is insufficient, although it requires careful monitoring, experienced operators, and close attention to vascular access, anticoagulation, device positioning, and potential complications.
If you've enjoyed our video, please press the like button and subscribe to support us so we can continue creating quality content like this.